Good morning, everyone. We're still letting some people join. Thanks for joining us this morning, and we'll get going in a few seconds here.
All right, good morning. I think that's my cue. We are going to get started. Good morning and welcome to Eggheads, the Colorado Health Institute's monthly webinar series. Before I start, I want to let you know a couple of things. First, this session is being recorded. We are also activating captioning for speaker remarks, which you can activate at the bottom of your screen. So please go ahead and do that. We will save time for questions at the end of the presentation. That said, if you have questions at any time, please feel free to drop them in the chat or throw them into the Q&A, and our team will respond as we are able throughout the presentation. I am Sarah Schmidt. I am the interim president and CEO of the Colorado Health Institute, and I am glad that so many of you are able to join us this morning. It's a rainy morning in Denver, and I think it has been a snowy morning in other parts of the state as well. So we have turned a corner, and hopefully everyone is looking forward to a fun weekend of Halloween celebrations. And speaking of Halloween, we always have a warm-up. We, of course, want to hear from all of you today. Our special question is, please hop over to the chat and tell me about your favorite Halloween candy. To inspire you, I brought some props in. Maybe it's Reese's Peanut Butter Cup. This was a favorite of some of our board members who were at CHI last week. So lots of fans of Reese's Peanut Butter Cups. I've also been somewhat partial to the Whoppers, though, too. So, you know, nothing like malted milk balls, not malted milk bones, although I think dogs would enjoy those. Let us know what are your favorite Halloween candies? Oh, Twix, but yes, I almost brought in a Butterfinger. Okay, someone loves Red Vines. That's pretty great. Love it. Any other? Don't we want to think about candy at 8 a.m. in the morning? It goes so well with our coffee. Dark chocolate Milky Way, Sour Patch Kids. All right, well, I love it. Now is the time for us to be thinking about candy. Let's indulge ourselves and keep them coming. Frozen Reese's Cups. Okay, sorry, this could take the whole day. Maybe we could advance to slide 2 if we can, please. While you're continuing to tell me about your favorite candy, I hope most of you know a little bit about CHI. If you don't, we believe that good health policy leads to healthier Coloradans. We are an independent and nonprofit health policy research and consulting organization. Our public benefit work is very generously funded, is funded by very generous philanthropic supporters, the Colorado Trust, Caring for Colorado, Colorado Springs Health Foundation, and the Zoma Foundation. We are very grateful for their support and the work that they allow us to do. We also consult with a lot of organizations, community groups, providers, state and local government, foundations, data analysis, evaluation, strategic communications. So if you are interested in partnering with us, please reach out. For the month of October, we'll throw in Reese's Peanut Butter Cups. I'm just kidding. But please reach out if you'd like to learn more about CHI. If we can go to the next here, the work we are going to be presenting today is part of our Integrating Systems of Care initiative. In early 2022, as we began looking ahead to our next 20 years, we identified 3 initiatives, really key priorities that we believe need crucial attention and action if we are to advance health and health equity in Colorado. So in addition to the integrating systems, which you will hear more about today, our other 2 initiatives are behavioral health and climate and health. If you would like to learn more about either of those, we will drop some links in the chat. You can rewatch some previous Eggheads web that we have had on those topics. You may also be interested in checking out an Eggheads webinar that we did earlier in the year on social health information exchange, which really sets the foundation for a good component of our integrated systems of care work. So I am pleased to be able to go off camera so I can try to not eat the candy that I brought into the office today. And I would love to turn it over to my colleagues, Ashley Brown and Kirsty Clavercamp. They are part of the team leading this work, and they are going to be sharing with us today about this initiative. So thank you very much, and I'll turn the floor over to Ashley and Kirsty.
Thanks, Sarah. Good morning, everyone. Thank you so much for joining us today. My name is Kirsty Clavercamp. I'm one of our program managers on the team here at the Colorado Health Institute. I've been working in Colorado for about 10 years now, and much of my work has been focused on care coordination, community and clinical partnerships, and social determinants of health. I'm really happy to give you a little look into some of our work here at CHI. We'd like to spend our time with you today so that you can walk away with a better understanding of what CHI's Integrated Systems of Care initiative is all about. First, we'll share what it means to integrate systems and why it's important. Stories are an incredible way to share information, understand different concepts, and connect with people. So we're going to start today with a story about a real person from the Denver area who provided permission for their story to be told. Second, we'll share lessons we've learned on how to effectively integrate systems, partnerships, and services. And third, we'll share a look into our vision for Colorado in 10 years when we've successfully built bridges across our systems and when people are getting connected to the services that they need. Our 3 takeaway lessons for you to look out for today are 1, follow the people, 2, trees grow where there is water, and 3, problems come and go, problem solving is forever. Let's move ahead and see how these takeaways come to light through a story and through our work. All right, what is integrating systems all about? I'd like to tell you all a story about a grumpy old man named Terrence. Terrence was born in the Cherokee Nation in Oklahoma. He was proud of his heritage, and he also spoke about the troubles in his life. His father left the family when Terry was only a few years old. His mother remarried to support the boys. Terry's stepfather struggled with alcohol abuse and never really liked him. His mother stuck up for Terry, but she also got into drinking herself. Being one of the oldest, Terry took care of his siblings. He eventually grew up and moved to Las Vegas. Terry was fond of his bold baritone voice on stage at the local venues and bars. Terry wasn't afraid to admit he was hurt in his 3 marriages and that he didn't have much left after that. His music career waned, and Terry started drinking alcohol to numb his pain. He barely made ends meet and had no savings entering his senior years of life. Terry had no family left, and so he moved into affordable housing in Denver. One day, a traveling nurse's clinic visited Terry's building, and Terry came for the first time in a while. He was known as grumpy, rude, and impatient, but one of the new care coordinators was determined to help. What she didn't know was that Terry would teach her more than she could have ever imagined. Terry felt forgotten. He felt like no one had cared in a long time, so he stopped trying to figure things out. The care coordinator took time to listen to his stories, and there were plenty. A trust was formed. Terry hadn't been to a doctor in years because he didn't know how to find one and didn't have a car to get there anyway. He was underweight, uncomfortable in his cluttered apartment, and sat with swollen feet, aching while drinking his daily dose of beer to forget his struggles. Terry wanted to be seen by a doctor because he was increasingly dizzy and weak. His care coordinator made an appointment with a primary care clinic down the road, arranged transportation, and met him there. The doctor was kind and concerned, but besides being able to evaluate his physical symptoms, the doctor didn't know how to connect Terry to any community resources to help him out with the other things on his mind. Terry's care coordinator was there to support and eventually made the connections he desired, but she quickly realized how disconnected and challenging it was to navigate a city of resources. It felt confusing and unnavigable for her, let alone others who were ill or unfamiliar with all the complicated systems. Fast forward to the hospital bed that Terry ended up staying in. He had compounded health issues exacerbated by a lifetime of unfair circumstances and personal challenges. His heart was failing. When it was clear that Terry wouldn't be going home because help arrived just too late, Terry and his care coordinator said their final goodbyes. She walked toward the hospital room door, and Terry placed his finger at the tip of his nose. It was Terry's sign he had taught her earlier. It means to love and to hope, he had told her, because that's all we can do. That young care coordinator was me, and it was such a difficult goodbye because I couldn't stop thinking that if the right support had been more accessible, or if someone had just taken the time to see Terry for the animated and quick-witted person he was, he could have gotten connected to the right resources sooner, so his story could have ended differently. It's people like Terry that show us again and again why our work is so important. We have a responsibility to continue acting on that love and hope that he shared by working to make our system stronger. And it starts by building partnerships and relationships across sectors and with communities to make our systems more coordinated and easier to navigate so people can get connected to the right resources, services, and support when they need them. This is what CHI's Integrated Systems of Care Initiative is all about. CHI has learned a lot about integrating systems of care by working with partners and communities across Colorado. We still have more to learn and more work to do, but we have key lessons learned already that will continue to guide us in making informed plans and decisions and action for Colorado. And now I'd like to pass it over to Ashley to share a little bit of these lessons as we take Terry's stories with us.
Thanks, Kirsty, and thank you so much for sharing that story. I think it's one of many stories that inspire us to keep doing this work, even on the days when it gets hard and kind of boring and technical. It's work that we're really passionate about. And hi, I'm Ashley Brown. I'm one of the directors at CHI, and I've been doing this work for nearly a decade to integrate systems of care for people like Terry, first in Massachusetts, and for the past 7 years right here at CHI. Over the years, we work very closely with many partners in this space, including a lot of familiar names that I see on the webinar today. Thanks for being with us. And thank you also to everyone joining this morning who's new to this work. This is really hard work that takes a lot of time and patience, and we're going to need all the help we can get to remake these systems so that they work better for Terry and others. We've learned a lot along the way. We have been doing this for a long time, and we can't forget those lessons that we learned as we continue to move this work forward. As Kirsty mentioned before, our 3 lessons are: first, we must follow the people. The current state is doing harm to the exact people that these systems are intended to help. Second, trees grow where there is water. We can't throw money at this problem without paying close attention to where it lands. And third, problems come and go, but problem solving is forever. The work we're doing today must build a stronger foundation for whatever happens tomorrow. So the first and most important lesson is follow the people. That's how we figure out where people are getting stuck. And this scene became familiar to many of us over the past 2 years. It's a COVID-19 community testing site in Douglas County, and you can see the line of cars winding around the lot with folks waiting for their turn. I'm guessing a lot of folks on the call today have a personal experience waiting in one of these lines or another line similar to it. So we're going to launch a poll. We're curious. Please tell us how much time cumulatively over the past 2 years have you spent waiting in line somewhere in your car, in a doctor's office, etc., to get a COVID test? Because this experience has become all too common, and it's also important to remember that our community testing sites were a historic achievement. The way that they were rolled out, they were very quick, they were very accessible. We were able to expand testing very rapidly over an incredibly short period of time. And at the same time, it's incredibly frustrating to make an appointment, arrive at your site on time, and then wait and wait and wait for your turn to get your nose swabbed in a parking lot. And this is a common experience that many of us shared, except for maybe the lucky few who were able to choose I never had to wait in this poll. So let's close the poll and see what we've got. See the results? Yay! All right, so we had a lot of people waiting. Only 9% never had to wait. Lucky you guys. Share your secrets in the chat of how you avoided that. But most of us were waiting up to an hour, 1 to 2 hours, over 2 hours. And this is a common experience that many of us shared, but it's also all too common for anyone trying to access any type of services. Because in many ways, our safety net has become an endless series of waiting in long lines to get your nose swabbed in a parking lot. And the language we use to describe the services, the safety net, invokes the image of a tightrope performer following into a secure net, and the net is wide and densely woven. There's no risk that the performer is going to fall through the net or miss the net entirely. But this language doesn't do justice to the real experience of individuals and families. The reality looks a lot more like this parking lot, followed by another parking lot, and then another. People need insider knowledge, infinite patience, and a good deal of luck to successfully navigate the available services and resources. It's so complicated that they also need a care coordinator like Kirsty to help them make it through. The need is so great here that we actually have many different workforces that are emerging to help individuals and families navigate our systems. There are community health workers, promotores and promotores de salud, care coordinators, case managers, patient navigators, patient educators, community health representatives, community health advisors, service coordinators, health navigators. The list goes on, and I'm sure we've missed entire workforces in this list. Please let us know in the chat if we've missed your favorite helper workforce. And each of these workforces is working really hard to hold this net together. It's a big job, the list is long, and yet the conventional wisdom is that we actually still need more helpers because the task is so large. Each of these workforces plays a slightly different role in holding the net together, but they have one thing in common. They all work directly to help individuals and families coordinate specific services. Now, in 2015, another workforce was born, the Regional Health Connectors. CHI worked closely with Trailhead Institute and the University of Colorado to develop and launch this workforce. And this workforce is a little different. Rather than providing direct assistance to individuals and families, RHCs focus on making connections between local organizations. Their mission is to improve health in Colorado by connecting the systems that keep us healthy, including primary care, public health, social services, and other community resources. This picture that you see here was taken at an event organized by an RHC to bring services to the community rather than asking the community to go to the services. RHCs live, work, and play in the regions that they serve, and they work with their local partners to plan and implement local solutions, including events like this one. But the most important contribution of RHCs is harder to picture. It's the relationships that they build within their communities. According to partner surveys, RHCs have created or strengthened thousands of connections, thousands, multiple thousands across the state. And this is really important work that must continue, but the RHCs are still facing an uphill climb because they're making these connections in their local communities when it's almost too late. And we have to start integrating our systems further upstream, which brings us to our second lesson. Trees grow where there's water. So I grew up on the plains. You can see for miles and miles across the pastures and grasslands until your eye meets a line of trees, and that is the river. Because where I come from, trees only grow around your house or along a river. Trees grow where there is water. And the same is true with money. Whenever you see a big institution, you have found money. Our society reminds me a lot of the plains where I grew up, because we can look out across our health and social services landscape and we see many big institutions, but we also see dry ground between them. And real people like Terry are getting lost there. This is not a secret. This truth is well known, and Colorado has already spent millions of dollars and many years on systems integration. Unfortunately, new dollars tend to flow through existing channels, like this river, and that can serve to reinforce the very silos that we're trying to connect. We cannot buy our way out by sending money through these same channels. We have to learn how to collaborate across channels and implement new ways of working. That will take money, yes, but money is not enough without a good plan and strong relationships to sustain systems change. Colorado took a big step forward in this work with the Colorado State Innovation Model. With Colorado SIM, we invested $65 million over 4 years to increase access to integrated care and coordinated systems. SIM included payment reform, practice transformation, population health, and health information technology components. The initiative supported over 300 primary care practices and mental health centers working across the state to integrate behavioral health services. And there was good news at the end. The evaluation demonstrated a positive return on investment, but also warned that sustainability was uncertain. Many practices reported that they had successfully integrated care, but they weren't sure how they would keep it that way without the ongoing support that SIM had provided. And according to the Colorado SIM final report, strong relationships and cross-sector partnerships were critical to success, both for what SIM had accomplished and also for future efforts. And the future is here. This work continued this summer with the creation of the Behavioral Health Administration. The BHA is charged with serving as the single entity responsible for driving coordination and collaboration across state agencies to address behavioral health needs. This is no small job. CHI created this very complicated financial map that you see on the screen here for the Behavioral Health Task Force in 2020. It shows the significant state and federal dollars that were flowing through multiple agencies to fund disparate programs. It's very complicated. The task force recommended the creation of the BHA to coordinate these services, but the work is just beginning. We still have a long way to go to achieve integration, even among behavioral health programs, let alone across sectors. And this is the part of the presentation where the work can feel totally overwhelming, and let's face it, not very exciting. This is where it gets a little wonky. So let's bring back the excitement with our third lesson. We've already talked about a few of the pressing issues of our day, including the pandemic and the behavioral health crisis. These can feel really insurmountable to us right now, but eventually they will either be solved or they will evolve. And then there will be new problems to solve, like jetpacks. This is where it gets exciting again. Now, a lot of people, including me, are very excited to get the jetpacks that were promised to us back in the 80s. But this leap ahead for transportation will come with its own new problems, like jetpack exhaust fumes, which will certainly be a major contributor of greenhouse gases, connecting to our other initiative on climate change. On the other hand, jetpacks could be an important tool in eliminating transportation issues. As a society, how will we balance the benefit with the cost? How will we decide who gets a jetpack and who should really keep taking the bus? At CHI, we believe that problem solving is forever, and the relationships and structures that we build today can help us solve the problems of the future. CHI serves as a trusted convener to help partners come together to make decisions. It's very complicated work, so we try our hardest to keep it as simple as we can. And in essence, it boils down to 3 steps. First, we have to build relationships between decision makers, and that includes the people who should be making the decisions, like the people who will be most impacted by the decision. Now, I take the bus to work, and I want to make sure that my fellow bus riders are well represented on the Jetpack Council. We should be talking directly to the jetpack manufacturers and the public health agencies who are monitoring air quality, among others. Second, we have to achieve consensus between partners on making decisions together. We won't get very far if some of us decide that jetpack access should be prioritized based on need, but the jetpack manufacturers still have the ability to sell to the highest bidder. The strong relationships that we built in the first step help us develop that consensus based on a mutual understanding of our different perspectives and interests. And finally, we have to follow through to implement the decisions we've made together. Now, my bus ride is very convenient. It's only about 20 minutes door to door. So honestly, I should be at the back of the line for a jetpack as much as I want one. And to make sure that happens, we might need legal agreements, we might need technology, or we might need people to enforce the rules to make sure I stay at the back of the line. We also need to monitor the implementation to make sure it's achieving the intended outcomes, which is included here in the ongoing governance. At this moment, some of you might be Googling, "Where's my jetpack?" and others, Sarah Schmidt, are thinking, "Wow, she's totally lost me with this jetpack thing." So let's get real. The Metro Denver Partnership for Health is a very real collaboration convened and facilitated by CHI. The partnership started back in 2014 with the local public health agencies serving the Metro Denver region. The LPHAs developed strong relationships with each other. They reached consensus on how they could make decisions together, and they identified shared priorities that they could act on together. And then they did it again and again over the years. The strength of this partnership that is based on those three essential components we just covered has allowed it to expand to engage the health systems, regional accountable entities, and county human service agencies that also serve the region. These partners have identified shared priorities across sectors, including behavioral health, immunizations, and social health information exchange. And each of these shared priorities have become complex initiatives in their own right. So let's dive a little bit deeper into the Social Health Information Exchange initiative. The MDPH Social Health Information Exchange initiative is powered by multi-sector work groups that focus on three key aspects: implementation, sustainability, and accountability. You'll see those across the bottom of this diagram. Over 30 different organizations are participating in these groups across those sectors, and each work group coordinates closely with the community board, which includes individual community members and community-based organizations that serve specific populations. For our purposes today, I want to focus on the role of the community board, and you can find more information about the entire initiative in the link that Kirsty just shared in the chat. So you can see in this diagram that the board oversees the work of all the work groups. This is very intentional. They have reviewed and provided feedback on everything that the work groups have done this year, from use cases to logic models. We are very committed to letting the board determine their own level of engagement, especially on the very technical issues that come up in this work. And we've set aside resources to support that engagement with stipends, training, and one-on-one conversations. We're very grateful to have 11 incredibly engaged members help us navigate the complexities of social health information exchange, and there's no reason that this structure couldn't also tackle the jetpack question in the future. MDPH is one of several strong regional collaboratives across the state, and some of this work has to be done at the local or regional level, but there's also opportunity to support these local groups with better statewide infrastructure. CHI is working with the Farley Health Policy Center and other partners across the state to develop a collaborative community response initiative that supports local collaborations like this designed by and for the people they serve. Which brings us full circle back to the first lesson. We have to follow the people. We won't know if we're going in the right direction if they aren't driving the work. So now I'll hand it back to Kirsty to help us imagine what the right direction could look like for a real person.
Thanks, Ashley. By now, we hope you all have the 3 key takeaways about integrating systems of care. 1, follow the people, like Ashley just reiterated. We need strong partnerships that include the people we are trying to serve to make it easier to connect to the services and care they need. 2, trees grow where there is water. Instead of simply pouring more dollars into existing channels, deepening disconnect and disparities, we need to think about new ways to nurture and sustain partnerships across sectors in Colorado to coordinate and collaborate. 3, problem solving is forever. Let's not look at this from a deficit standpoint. Let's look at this as an opportunity. We have the tools to face each new challenge that comes to us, the relationships, consensus building practices, and shared decision making. Let's harness these tools and imagine a world where Terry's story could have ended differently if our systems were better connected and coordinated when he needed them. Imagine if when Terry arrived in Denver, the service coordinator working at his affordable housing building was part of a cross-sector network of partners and providers. The service coordinator would have navigated Terry to resources and options that were available, and sooner. Terry would have felt supported and felt like the providers and services and the community around him were reachable. When our traveling nurses clinic came to visit, we could have worked alongside the building service coordinator to support Terry in maintaining his well-being and health, rather than responding to a crisis when it was too late. With more integrated services and supports, Terry would have seen his hope and love for the world around him realized. It's that hope that Terry shared, which he called out with the point of his finger, that I will never forget. That reminds us of the Colorado we want to see in the future. And what does that look like? If Terry's story could have ended in this way, in this new light, we would know our vision for Colorado has been realized, where Colorado's leaders know how to make efficient and effective decisions together, where Colorado is making smart investments to ensure accessibility and capacity of services, and people can connect to the care and services that they need. This is the vision that we have for Colorado, and one that we believe we can reach together. Thank you so much for joining us today. We're really grateful for your time. We will leave time for some questions and comments, but first we do want to invite you to the Hot Health Conference. It is December 9th. Just a little bit of information. We have a limited number of scholarships available to support people who wouldn't be able to attend otherwise. We will have translation services available for in-person. For anyone who joins online through some generous support, registration will be free, and we will also have enhanced options online for accessibility, including closed captioning and Spanish interpretation. So please, we'd love to have you at the Hot Issues in Health. Check out the webpage for more information. But now we'd love to leave some space for questions and comments. If you could raise your virtual hand, that'll make it really easy for us to find you. And don't forget to join us next time about check packs.
I see we have one question in the Q&A from David. Thank you for your question. David, do you want to ask your question live? 25, David. David, raise your hand so that Deanna can find you and unmute you.
There he is.
You
David,
made me
Yes.
cry, Kirsty. You made me cry. That only happens once a month, so thank you. And what I've discovered is that by using that first rule, so much else just falls into place. If you just keep coming back to that rule of how does it help Terry? What would Terry do? The problem is that there's no Terry agency. There's a behavioral health agency. There's a physical health, multiple agencies. So the question I didn't pose in writing is, how do we have a Terry agency? How do we get the trees growing around Terry, number one? And then the sub question is, how does $26 million for care management and behavioral health support Terry? And how does a similar multiple millions for HCBS care management support Terry, as opposed to supporting a home care person and a behavioral health care coordinator, just like a physical health care coordinator and a housing care coordinator and a great presentation, guys.
And a great question, David. And I think that really goes back to our second lesson, right? Is that we, for better or for worse, mostly for worse, live in a world of silos. And a lot of the money that's available to support people like Terry is trapped in those silos due to federal regulation, historical bureaucracy. There's all sorts of reasons that is true, and it's going to take us a really long time to connect those silos. And I think we can expect that money is always going to flow through channels, right? As a farmer's daughter, I know a lot about irrigation, and I think the analogy is really similar, that you have to have a channel for it to flow through. Or a pivot, right? Pivots are a great technology. Maybe we can figure out how to get pivots into integrated systems of care so we can water the entire field. But until we build pivots, we've got to have rows between our corn that is making those plants grow, and that's the world that we live in today with our funding streams, right? And so I think what we should focus on as a community who cares about this issue is, how do we work with the stakeholders that are making decisions about those funding streams to make sure that they do support this overall vision, and that we're leveraging those dollars that are available for connected and coordinated systems. And I'll give some props to the Behavioral Health Administration, and especially our dear friend Kristen Laura, who's thinking really carefully about that in her new role at the BHA, and working closely with OHI and HCPF to think through, how can we make these dollars for BHA and these dollars for HCBS and all of these dollars work together? How can different parts of the state build different pieces of the connection so that in the end we get connected systems across systems, even though that's not how the dollars are flowing to us right now. And frankly, in our current political environment, probably won't have pivots anytime soon. So I think we can work on pivots, but we also have to figure out how to connect those irrigation rows to really get to the things that we want, no matter where those dollars are sort of allocated upstream.
Rachel Art Steinberg, if you would raise your hand, we could spotlight you as well and have you talk.
Here I come. Sorry. Took me a second there. Yeah, I just wanted to say thank you so much for sharing Terry's story. I worked in a care coordination program for about 7 years and worked with a lot of individuals. And, you know, that story just sounds so familiar. And I just know firsthand how integrating systems can really improve people's quality of life and, you know, make things more efficient. Here in Northern Colorado, you know, we had a pretty cool setup where, you know, we had an FQ in the same place as our offices, and we also had integrated behavioral health there, and we also had a cold weather shelter there, so we could help individuals experiencing homelessness. We also have WIC on site, and just, you know, that those programs alone, having them in the same place, just really helped with a lot of stories just like Terry's. So I just want to say thanks for sharing that story. Like David, you had me crying at 8:05. So thanks for that.
Thanks for speaking up, Rachel. It's always nice to hear someone else join us, right? And yeah, that story is very near and dear to me, but we also know, unfortunately, it's not unique. And so thanks for sharing experience from your part of the state. We truly believe, right, it's going to take all of us working on this and remembering the people that we learned from.
Absolutely. Absolutely.
I have a question in the chat from Christopher McDowell. How do we engage your expertise in our region and locale? And Christopher, if you'd like to raise your hand so you could talk with Christy and Ashley, please feel free.
Can you hear me? Great.
Yeah.
Hey, what a tremendous presentation. And it's very much what we're trying to do out in our neck of the woods in a rural setting, which adds a whole nother layer of issues, as you guys probably know and recognize. But just interested on how to partner with you and add to our efforts as we work with our community to provide a better net for our community, not just in healthcare, but in social needs. All those things that we're all passionate about. And thanks again for that story. That was a great story. Been there, done that. I'm a physical therapist, home health guy from way back, so I get it. Thank you.
Thank you for that question. We are working with communities across the state. We wish we had time to highlight all the work we're doing in this space, but we would love to work with you and your partners. And the best way to connect is to reach out to Kirsty and I via email. We'll put our emails in the chat. We are engaged both at this regional level that is really focused on regional collaborations and what can we do to solve this at a local level with several regions across the state, including Metro Denver, but also including Pueblo, other places. And we're also engaged in some really exciting statewide work to support all of these regional and local collaborations, including the collaborative community response that I mentioned earlier, and also work with the Office of eHealth Innovation about what they can do with other state agencies to support this work statewide. So we have sort of multiple levels of engagement, and we'd love to talk with you about how that engagement could make sense for your partnership. And maybe it's all of the above, because that's so often the case. And I see we have an anonymous question in the Q&A that I'll address. And while I'm doing that, Danielle has a great question. Danielle, if you want to raise your hand, we can get you off mute to ask that question live. The anonymous question, while we're getting Danielle set up, is that the Metro Denver Partnership for Health seems to continue to be successful for the community. Yes, we think it is. Is CCR, the Collaborative Community Response, a vehicle you see as having some potential to scale this project to other Colorado communities? Are there plans for scaling? Yes, yes, and yes is the answer to all of those questions. We are working really closely with the CCR team, David, who asked our first question, and others. And CCR is really kind of that pivot idea, right? Of like, how do we actually remake the system and build a pivot to change the way that things are funded to accelerate this work? And so we see a lot of potential there to scale this work across communities to make this easier. And we also are doing sort of piece by piece scaling in the meantime, right? Working with local regions and sharing what we've learned in the Metro Denver area. And we'd love to talk with everyone on the call today about how we could support your local efforts as well. So please reach out to us. I'll pause there and let Danielle ask her question.
Hi, can you hear me?
We can.
Okay. So I was just saying, I just finished being part of a phone campaign for the Colorado option. And we were also telling people about the Prescription Drug Affordability Board. So great news for, lower income folks and undocumented folks and contract workers, but it was hard to reach people and have the conversations that would help low income or undocumented communities. So I was just wondering, is implementation of reaching people virtually by phone or email a part of this model? It seems especially important in the COVID world, since we can't, go door to door and maybe reach more people with that face-to-face contact.
Yeah. Thanks for the question, Danielle, and thanks for doing that work on the campaign. The answer is yes, and really the vision here, right, is to go where people are, where they have trust relationships, where they are already seeking services. So I think part of it is truly being in person, right? If I'm going to my neighborhood food pantry, being able to go there and get connected to services I may not otherwise know about. But to your point, right, there are a lot of different mediums of communication that work for different people at different times of their life. So the idea, implementation, right, would be all of the above. Maybe phone is how they like to communicate. Maybe they'd rather communicate via email or text to get connected. But for other people, in person is still really important. So I think that's part of the partnership, relationship building, figuring out what's working best in that community and for whom in the way that they would like to access services. I hope that's helpful.
Okay, thank you.
Yeah. Hey. Not seeing any other questions in the Q&A come through, but we're always happy to pause to give people time to think.
While you're thinking, we have a shout out to Chris, who asked a question earlier from Angelina, that Chris is doing really amazing work in the Roaring Fork Valley on the Valley Health Alliance. They're pioneers in meeting the quadruple aim, bringing employers, providers, and payers to the table to assure affordable, high quality care in the Roaring Fork Valley. So kudos to Chris, and also all of you who are doing this great work across the state. We know that we are not the only ones. We're working with many of you to support your efforts, and we know there are many more that we don't even know about, and we'd love to learn more.
Thanks, Ashley. Any final questions? We have a few minutes left with you all if you have any burning questions or other ideas or connections for us.
I also welcome anyone on the call who's working on something like this. Raise your hand and tell us about it. We would love to learn things on this webinar this morning as well, if you would like to share with us in the group.
Kelly.
Hi, everyone. Kirsty and Ashley, I just want to say thank you for a great presentation and talk a little bit about Family Connects, which is a program that I've been working on with a lot of partners to bring to Colorado. Illuminate is the state intermediary agency. I work at the Public Health Institute at Denver Health, so we're working on bringing a local site to Denver and Jefferson County. And a lot of what you're talking about really resonates with some of the goals of Family Connects, which is to have a community aligned system. So the program is a universally offered nurse home visiting program that offers, it's a light touch, we call it, which is a 1 to perhaps 3 home visits by this nurse where a physical and psychosocial assessment happens and helps refer families to services. And what the Family Connects International, which is the purveyor of this program, likes to call the secret sauce of the program is really the behind the scenes community alignment that supports those connections for families in the newborn period to the existing community resources. And so we are trying to build that out locally, and we have we've been working with Ashley and Kirsty to support kind of the the technology that will help connect families to different organizations. And we also know that those individual relationships between organizations are so important, not only to the families, but also to the people making the referrals. They want to trust, the agencies that they're referring to. But one of the things that I want to bring up, and I've encountered this in my work, is sort of especially, and I think this gets back to your lesson of trees grow where there's water, is on the one hand, community-based organizations want to be successful and serve their community. And I've also witnessed sometimes a reluctance to perhaps be connected to big infrastructure things like this that could potentially overwhelm them. Like, we want to find the families, and gosh, we actually don't know how many families are out there, and what if we have to start turning families away? So I'm curious about how the systems thinking addresses that issue and helps us connect families to those needed services, and helps those services grow with the demand that may be created.
Ellie, this is such an important conversation, and one that the sustainability work group for SHIE is really squarely focused on. In our last meeting with them, we basically came to the decision that we're not going to worry about funding the technology. Technology finds a way to fund itself. What we really need to worry about is how are we going to fund our community-based organizations? Because we've heard many of the same things from community-based organizations, that they're already at capacity. They aren't sure how they could possibly serve anyone else, let alone do the administrative work to actually connect into a system like that. And we've heard from some of our partners that they actually have free referral platform licenses that they're trying to hand out to community partners, and they're being declined because the community partners don't have capacity to learn a new system, to do any of that. They're really stretched thin. And so that's going to be a critical component of making these connections, right? If we're making connections, we have to make sure that money is flowing somehow with those connections to support those services. Otherwise, we're going to end up making the infamous bridge to nowhere, right? And this is a big lesson learned that came out of a report from the Camden Coalition a couple of years ago. For those of you who aren't familiar, Camden is sort of famous for popularizing the hotspotting idea of really targeting high-cost patients and trying to connect them to services to bring their costs down. And they've been lauded for years and years as the model for how to do this. And they very bravely published their own evaluation that showed that it wasn't as effective as they were hoping after a few years. And there were two reasons for that. One was, for all the data nerds in the audience, regression to the mean. When you're targeting people who are at the peak of their cost, just statistically, they're likely to go down. And so when you compare that across a control group, you see the control group also going down. So that's the nerdy answer. But the answer that's more relevant to this conversation was that there was also a problem with this bridge to nowhere, that they were connecting to services and then they couldn't get those services actually provided to the populations they were trying to serve. And so no amount of care coordination is going to help if there's nowhere to go on the other end. So we really see the CBO capacity, both in terms of providing services, but also in terms of the administrative competencies and time that is needed to connect into these systems. That has to be funded. The CBOs do not have extra money lying around to fully engage in the system, and we cannot succeed without them. So super critical question. We haven't figured out the answer yet, but we're talking about it literally every day, and we would love to invite others into the conversation and really try to figure this out together, because that's what this initiative is really all about. Is it's going to take all of us to remake these systems. They've been in place for decades and decades. They're not going to change overnight. This is really complicated, hard work that we need to come at from a lot of different perspectives.
Thanks, Ashley. I think the only thing I have to add that's been really part of our conversation with our partners is this inherent need to think about capacity more holistically. I think a lot of times we've heard when we talk about community-based capacity, it's often thought of or talked about in a transactional sense. I will give more money for services that will increase capacity. At a certain point, yes, right? But we also need to think about infrastructure building. And so I often use this example over and over again. So those of you who know me well have heard it. But if we think of maybe like a local partner like Volunteers of America, if their kitchen is only a certain size, right? It doesn't matter how much money we give to actually allot and prepare the meals if they don't have a big enough kitchen, right? And so I think something that we need to really be intentional about as we are developing those relationships with CBOs is really listening about where they're at and what they truly know they would need, right, to like scale up to meet that demand. So that's my only bit I wanted to add to that, because I think that's something that we're really going to have to be challenged by, but it's an opportunity for us to think through as we're building more community and clinical partnerships moving forward. Let's see. I think we probably have time for one more question, right, Ashley? I saw Rick raise his hand. Rick, if you want to come off mute.
Yes, hi, Rick Kurtzinger with Quality Health Network and the Community Resource Network. Thanks so much for this. In terms of talking about funding and making sure that we have the resources in place, one of the things that we've been really excited about on the Western Slope is that we've now seen a couple of organizations use data from CRN and the HIE to be able to show their success and their need and dealing with and helping some of their clients. So they've been able to write that into grants to be able to secure additional funding because they were able to show the work that they were successfully doing, which they knew anecdotally before, but having that demonstrated success has helped them secure additional funding to expand the scope of their work, which has been really exciting.
That is such a great point. And it goes even beyond grants, right? That also is helpful for negotiating new contracts and for attracting different kinds of funding streams. And that's really one of the things we often hear from providers is like, oh, I don't want to screen and refer if there's nowhere to go. So I'd rather just not know. And we keep saying, no, the data itself can be powerful. Even if the system isn't quite ready, the data can help us demonstrate the needs. The data can help us demonstrate the impact of even a small pilot. And that data is really critical to help tell the story to people who can make decisions about those funding streams and help advance this work forward. Thanks so much. First, for all the great work you're doing on the Western Slope with CRN, Rick, we love that. And also for raising that really important point about the power of data to help us move this work forward. All right, I know that we could talk all day with this group about this and probably into next week. We are almost at time, so we're going to wrap it up. But there's another opportunity coming soon that Kirsty already told you about, Hot Issues in Health, on December 9th. We're really excited to have another session dedicated to integrated systems of care on the agenda, and we're going to reserve a lot of time in that session for attendees to talk to each other about what you're doing in this space. So thank you, Kelly and Rick, for kicking that off with telling us a little bit about your initiatives, and Chris. We're really excited to learn more at Hot Issues and hopefully in between now and then, and we really hope to see you there. We're excited to continue the conversation.
Thank you, everyone.